This conference will now be recorded.
Perfect. And then did you want to wait for a few more people to show up?
Yeah.
Okay, sounds good.
So I'll turn record off maybe.
This conference will now be recorded.
Awesome. Well, welcome everybody to the Hearing Loss and Cognitive Decline webinar. Dr. Illich is your host, and he's been working in audiology since the 80s. So I'm gonna let him take over and enjoy.
Good morning, everyone. How are we doing? I hope you're doing well. I'm Dr. David Illich, and I've been the Chief of Audiology for Palomar Health since the 1980s. And today's talk is the connection between hearing loss and cognitive decline. Now, before we start, I like to start off with a little bit of humor. So a smile is always a good way to start anything. The doctor's at his desk and the nurse comes in and says, doctor, we have a problem. We have a patient in the lobby who demands to see you. And the doctor said, what's the problem? And the nurse said, the patient says he's invisible. And the doctor says, tell him I can't see him. Ha ha ha. All right, so we're going to start off with a few little caveats. First of all, I am not a professional speaker. I might give three or four talks a year. So I may be referencing some of my information. So just kind of bear with me. Initially, when we put this together, I had hundreds of slides and I got it down to 108. So in 40 minutes, we're going to be going fast and furious. I'll try to be as clear as possible. At the end of the talk, we're going to have questions and answers. We'll have my phone number, my email, so you can also contact me if you have further questions. Now, real briefly, as I said, I'm Dr. Illich, and I'm part Southern California, part Southern Mississippi. I was born in Victorville, California. My dad was in the Air Force, and I was raised in the beautiful city of Long Beach, Mississippi. I received my master's degree at the University of Alabama at Birmingham. I got my doctorate from the University of Arizona, A.T. Stills. I've been in San Diego, North County since 1982. I started my private practice, Professional Hearing Associates, and we're the primary provider of audiology and hearing services for most of San Diego, North County's hospitals, clinics, and school districts. I'm married to a beautiful second grade school teacher, Kathleen. We have 2 children. Our son, Michael, is also a 3rd grade school teacher here in Escondido, and our daughter is finishing her master's degree up at the University of San Francisco. Now, here are the 4 wonderful audiologists that I get to work with. From the left to the right is Dr. Heather Cones, Dr. Shannon Clemens, and Dr. Clemens was born and raised here in Escondido. Dr. Catherine Alsbury and Dr. Amy Marin. Now, being a Southern boy, I love quotes and colloquialisms, so we're going to look at 2 of these. One of them is from Socrates. And Socrates said, the ear is the organ of education. The second one is from Helen Keller. Helen Keller said, our eyes keep man in contact with objects. With the eyes, we can see the beautiful faces, the beautiful colors, but our ears keep man in contact with man. Now, we're going to stay organized today. We're going to touch briefly on my very favorite topic, anatomy and physiology. I love anatomy and physiology. We're going to talk about the types and causes of hearing loss. We're going to talk about different types of audiological testing and the impacts. And then we're going to get to the crux of our talk, hearing and cognition. And real briefly, we're going to end it with just a few slides on some of the emerging technology that's come our way over the last few years. Now, first of all, my voice is setting off vibrations, and those vibrations are going into your ear canal. Now, the ear canal is called the external auditory canal. It goes down the ear canal and it hits the eardrum. Another name for the eardrum is the tympanic membrane. Believe it or not, the tympanic membrane is only about 3 cells thick. It's a very, very, very thin membrane. The tympanic membrane vibrates and it makes the ossicles, the 3 smallest bones in the body, vibrate. The eardrum makes the malleus, the first bone, vibrate, which sets off the second bone, the incus, and then the stapes. Now, here's some trivia for you. These are the only 3 bones, these are only bones in the entire body that do not grow from the time you're born. So there's your some cocktail party trivia right there. Now, the stapes vibrates the oval window, which is the inner, going into the inner ear. Now, the oval window is very tiny. The sound that the stapes vibrates into the inner ear is 20 times plus more powerful than what hit the eardrum. So those little ossicles, they're acting as levers. So the ossicles vibrate and it goes into the inner ear. The fluid inside the inner ear, we could spend an entire talk on this and I would love it because like I said, I love anatomy and physiology. The fluid in the cochlea vibrates. The organ of Corti, it's a little membrane inside the inner ear. And right there where the arrow is where the high frequencies are. And you go further and further into the cochlea and you get more to the base of the lower frequencies. So the outer part of the cochlea is where the high frequencies are. And the high frequencies are the first to go due to noise, due to age, due to a lot of different things. Now, in the inner ear, on the left, we have healthy, normal hair cells. Look at the ones on the right. Those are damaged hair cells. Oops, I just made a mistake. All right, this is what we're going to talk about today. And I could spend a whole day talking about this. I don't care about the ear. An audiologist who does not care about the ear. What I care about is the auditory nerve, all of the connections and all the stops from the auditory nerve going into the auditory cortex, the brain itself. When the sound leaves the cochlea, it goes to the ipsilateral cochlear nucleus. That's the first stop. And what the cochlear nucleus does, let's say the sound goes in the left ear. The ipsilateral cochlea sends the sound to the right side. It keeps some on the left side, but it sends a lot of it to the right side. Then it starts to go up. Now, each one of these processes, the ipsilateral cochleus, number 3, superior olivary complex, number 5, inferior geniculate bodies, they all have different responsibilities. And actually the sounds go back and forth, back and forth, back and forth before they go into our auditory cortex. Now, the auditory cortex is inside of the temporal lobe. There's 4 lobes inside of the brain. The temporal lobe is located right above your ear. So as these sounds go up, and then they cross one more time into the corpus callosum. So there's many cross sections, many points where it stopped. Now let's compare this to the other senses. Hearing, listening, understanding speech is so much more complex than any other sense. Now, vision has one stop, the thalamus, before it goes into the brain. Smell doesn't even go through anything. Doesn't go through the mouth, thalamus, it goes through nothing. It goes directly to the brain. And once again, the cochlea, all these different little stops back and forth and back and forth and back and forth before it gets to the thalamus. The thalamus is the last place it goes before it goes to the brain. So by far, our hearing is our most complex, unique, individual sense. Now, once the sounds are in the brain, then the brain sends them to 5 different locations. Most importantly, it goes into memory. What does this word mean? It goes into emotional part of the brain. How should I react? It goes into sound analysis. Was that a dog barking or was that a train coming? It goes into speech recognition, which is called Wernicke's area, and it goes into the executive function. Now, what is executive function? Executive function is the most complex part of the brain. It's what decides attentiveness, decisions, reasoning, all of that type of stuff. So when the sound goes into the auditory cortex, then the auditory cortex sends out to all these parts to put the whole picture together. The brain interprets 25 to 30 phonemes per second. 25 to 30 phonemes per second. Compare that with vision. Could you imagine seeing 25 to 30 things per second with your eye and interpreting it? It's a dog, it's a ball, it's a house. It's an amazing. I could spend a whole day talking anatomy and physiology, especially with the ear, because it's so remarkably complex. Now, what we're going to talk about today is we don't hear with our ears. I mean, we do hear with our ears, but we listen with our brains. Now, what is hearing loss? Hearing loss is any degree of impairment in the ability to apprehend or comprehend sound. It could be sudden, but usually it's very, very gradual. And the most important thing of all, hearing loss is as unique as the individual suffering it. There's a sonic footprint. We're going to talk about Nina Kraus in a little bit, one of the most amazing neuroscientists in the world. And she does more studies of the brain and what happens in there to just about anybody. And that's what she calls it, a sonic footprint. The way that we process speech, the way that we interpret is so different from individual to individual. Now, right here with what is the hearing loss? One thing you notice is it doesn't necessarily say you can't hear the soft speech. There's a lot of people who have hearing loss who have normal auditory sensitivity. And we're going to talk about that in just a moment. Okay, let's talk about the types of hearing loss. This is pretty easy. There's only two types of hearing loss, kind of. There's conductive hearing loss and there's sensorineural hearing loss. Now, conductive hearing loss makes up maybe about 5% of all hearing loss. And what it is blockage in the outer ear or the middle ear. It could be earwax. It could be damage to the eardrum. It could be damage to the ossicles. It could be negative pressure or fluid inside the middle ear cavity. Conductive hearing losses usually can be medically correctable. All right, here's some conductive losses right here. The one on the left is a middle ear infection. I see this every day of my life. In the middle is a gorgeous, perfect, beautiful eardrum. That's what we love to see. You can see the malleus. You can see the outer middle ear bone right there in the middle. And you see that little light? That's called a cone of light. It's a hallmark of a healthy middle ear. And then another thing we see daily on the right is packed earwax. People say, I'm surprised I have packed earwax. I'm really surprised because when I use my Q-tip, I take out lots of wax. And we say, yes, but do you know how much wax you're packing in there harder and deeper? And you can see what we see with impacted wax. Now, 95% of all hearing loss is sensorineural. Now, sensory, cochlea, neural, nerve. And that can happen due to age, that can happen due to noise, that can due to medication, genetics. So 95% of all hearing loss is sensory neural. Here's another slide of a nice, gorgeous, healthy cochlea, inner ear. And then on the right-hand side is a severely noise-damaged cochlea. Okay, what are the causes of hearing loss? People say, why me? Every day, why me? We're all human. Now, there's 4 different causes of hearing loss: presbycusis, sociocusis, congenital, and ototoxicity. Now, another name for presbycusis is the aging blues. We all go through it. Men start to lose a little bit of their hearing in their early 20s or 30s, and ladies are made better. It might be in their 30s. So we all lose maybe 1% a year. Why do people with hearing loss not often notice they have a hearing loss? Because if you lose 1% of a body function per year, are you going to notice it? No. So presbycusis is age-related hearing loss. Secondly is sociocusis, and that's how I got my hearing loss. I wear hearing devices because in college I worked on a pipeline with a jackhammer and a Case 580C backhoe, and I was not smart enough to wear ear protection. It can be from hammers, it can be from music, it can be from anything, but noise-induced hearing loss is called sociocusis. I am having a little trouble with my slides, guys. I apologize. Oh my goodness, what happened? I think lines are coming back so I can fix this. Hold on one second. I think we're coming right back here. All right, so bring this down a little bit. My apologies, y'all. And then after socioacusis is congenital. We are our parents. And then lastly is ototoxicity. Now there's more than 200 different medications that cause hearing loss. That's a job that we do quite often, is if a person's on different types of combinations of gentamicin and streptomycin, which might be ototoxic. Oto means ear. Toxic is toxic. We have to monitor those patients. Now, hearing loss is extremely common. About 12% of all Americans have significant hearing loss. That's more than 38 million people. Let me ask you a question. Why is that 12%? Why is that 38% going up significantly right now? Why logarithmically are those numbers going up? Why? Baby boomers. Every day, 10,000 Americans turn age 65. So that 12% and 38% at this very moment are going up quite quickly. The comment I made a moment ago, hearing loss is the third most common physical issue for people over age 50. Now, arthritis and hypertension are number 1 and number 2, but number 3 is hearing loss. Degrees of hearing loss. Now, a basic audiogram measures 2 things. Across, up, and down is how loud is the sound. At the top right here, we have normal, then it comes down to a mild hearing loss. Now, mild hearing loss is not a mild hearing loss. I'll explain in a second. Then you go down to a moderate hearing loss, then you go down to moderate severe, then you go down to severe hearing loss, and the profound means deaf. Why did I say a mild hearing loss is not a mild hearing loss? You want to see what a mild hearing loss is? If you're a professional or somebody with normal hearing, somebody who wants to see what their spouse is going through, get a pair of little bitty yellow plugs and put inside your ear canals and wear them for a few hours to try to communicate. These little plugs will give you about a 27 dB loss. Now, normal hearing is 0 to 25. So all you're doing is you're giving yourself the mildest of mild hearing losses. And you're going to feel how much energy you got to use to strain, to hear conversations, to interact. And within a couple hours, you're going to find yourself not wanting to, and you're just going to find yourself interacting. So up and down, we have decibels, loudness. How loud is the sound? Now across the top, we have frequencies or pitch. On the left, we have 250 and 500 hertz. Those are low bass frequency sounds. Boop. Then you go across boop to 4,000, 8,000, which are really high pitched sounds. Have you ever heard somebody can say, I have difficulty hearing my wife, but I think my hearing is good? Every audiologist in the USA hears that every day. I have good hearing. It's my wife and children who mumble. The reason they can say that with a straight face is because on the right-hand side are where most of the vowels are located. And vowels are powerful. A vowel will go through a wall. A-E-I-O-U. I-E-I-O-U. 80% of speech energy comes from the vowels. Powerful sounds, like a tugboat. Boop. Low frequencies are powerful, but they only give us about 20% of the clarity of speech. On the right-hand side are the consonants. Now, the consonants are the opposite of the vowels. They're very, very, very soft sounds. B, C, D, F, G, H. Please do this for me. Say a word softly, say a word loudly. Cat, C-A-T, softly, loudly. You've just said the A softly and loudly, not the C or T. You see the audiogram, the hearing test? This guy hears the vowels perfectly. I-O-U. It's losses with the consonants. That's why this guy can say, I can hear good. It's my wife and children who mumble. Now, real honestly, that audiogram I just showed you, it's a very poor predictor of a patient's ability to understand speech. If you're testing speech, test speech. When I look at an audiogram, one of the first things that I'll look at is the word discrimination score. Now, the word discrimination score is you give the patient perfect hearing. And what's the ability of the brain to understand the speech? How do you give perfect hearing? You have a headset on, which is a perfect proximity. You're in a soundproof booth, no background noise, compact disc player, a man with a perfectly trained voice at a comfortable intensity. Say the word go. Say the word up. Now, if a person gets 90 to 100% of those words, they're going to do perfectly with a hearing aid, or they're going to understand speech great. If they do to 70 to 90, they're not going to do perfectly, but they're going to do really, really good. Now, if your word discrimination score is 60% or less, the audiologist needs to talk to you about realistic expectations. The hearing aid is going to help you tremendously, but you will still miss a lot of words. Now, the most important test is called SIN, speech and noise, or the quick SIN test. And what you do is you have the patient in the soundproof booth, you have ambient noises going on. How well can a person understand speech with background noise? So what this does for the audiologist is it helps us create exactly the outputs, the directionality, the amount of compression. It's one of the most important tests that we do. We also use some questionnaires. We use the Montreal Cognitive Assessment. There's different types of questionnaires that we can do for cognitive. Now, with hearing, you can't measure unless you monitor. We have questionnaires. How well is the person doing with the hearing aid? There's the COSI. There's different types of tests that we can monitor the patient during the trial period to see how they're doing with the hearing aid. We also use questionnaires for our testing, like the tinnitus handicap inventory, which is the first step that you take when you're trying to evaluate the effects of tinnitus on a person. There's the dizziness handicap inventory. We work a lot with dizziness and vestibulars and such. Here's the COSI, which we use to monitor hearing loss and how the person's doing with the hearing aids. And here's another one that's very, very popular, the International Outcome Inventory. Let's talk about three different types of impacts. There's social, psychological, and physical. Let's talk about social first. Back at the University of Alabama a long time ago, we did a study where we found that about every 6 months, you comfortably give up something you love. You might not want to go to church as often because it's embarrassing in the foyer talking to people and you can't understand them, but it's no big deal because you've got a good religious heart. 6 months later, the wife is complaining about you playing the television too loudly, but it's okay. You go to the back room, you watch Sports Center, you don't bug her, it's great. 6 months later, you don't want to be around the grandkids as much because you misinterpret so much of what they say, but that's okay because they're a different generation. So you come up with an excuse. There's isolation, there's inattentiveness. You see this with people who lose hearing loss later in life and also with children with middle ear problems. And a child who has a lot of middle ear problems, they really don't like to interact. It's too exhausting. They just withdraw from life. There's the psychological impacts, worry and frustration, anxiety, and low self-esteem. There's a brilliant study that came out real recently on self-esteem with young adults with untreated hearing loss. And then today we're going to kind of talk a little bit more about the physical impacts. At the end of this talk, I'm going to offer a packet of information. I'll have my phone number, my email, my website. So I'll be happy to get you any of this information. How does hearing loss affect heart, eyes, depression, obesity, isolation? So there's a lot of great data on this one sheet here. Now let's talk on three of them. Hypertension, diabetes, the first two. And they have to do with the fact that the smallest microvascular system in the entire body is the cochlea and the vestibulars, the ear. They call it the canary in the coal mine. Before damage occurs anywhere else in the whole body, anywhere, it occurs in the cochlea and the vestibular because those are the smallest blood vessels in the body. People who have high blood pressure have significantly higher hearing loss. And with diabetes, the talk that we gave in springtime, hearing loss is twice as common as people with diabetes than without. Now, here's to me is one of the most amazing factors. A person who has high blood sugar, they're not enough for a diabetes diagnosis, but they have high blood sugar. That population has 30% higher rate of hearing loss than people with normal blood sugar. That's really incredible. Once again, I'm working with some slides that are having a little trouble, so forgive me. And then we work in rehabilitation with physical therapists, occupational therapists, and such. This is very important. People with a mild hearing loss. What's a mild hearing loss? 25 dB, that's right, are 3 times more likely to have a history of falling. 3 times. I've lost more patients to falling than anything else. Now, every 10 decibels beyond that 25, the chances of falling increase by 1.4. We're going to talk more about this in a second, but obviously what we're talking about today is what happens inside the brain with hearing loss. One thing I forgot to say, no, it's just coming up in a moment. And really and truly, it just goes back to the oldest rule of anatomy and physiology. What is the first rule of anatomy and physiology? It's if any muscle and or nerve, if not properly stimulated, will continue to decrease. The short version is if you're not going to use it, you're going to lose it. And then there's other effects, fatigue. I actually forgot my hearing aids one day. And I can tell you this, and I have a very, very, very mild hearing loss. And I had to strain a little bit more, just a little bit. But at about 5 o'clock at the end of that day, let me tell you, I was exhausted. I had a headache and I was ready to just lay back on the sofa and close my eyes. 2 slides on COVID, yeah. Face mask. They take down hearing about, clarity down, hearing about 12 decibels. Now that's about 20% of speech clarity. So do the mask affect our ability to communicate? Heck yeah, 20%. Take 1 out of 5 letters out of any sentence and try to figure it out. Now, one of the little masks that I had been using, and we still have to wear masks at the hospital. We still have to wear masks in all 3 of our offices. We have offices in Poway, Oceanside, and Escondido. And we still have to wear masks. And the clear masks do help people see better, which improves. All right, showtime. Now we're going to get onto the topic that we all came for, hearing and cognition topics. And we're going to hit 4 different areas. We're going to talk about what is the relationship between hearing loss and cognition. What do we do about hearing? What do we know about hearing loss and cognitive performance? Is there a link between hearing loss, cognitive decline, and dementia? And the most important thing of all, what can we do to intervene? Now, here's the most important part. This is the most important part. We are just beginning to understand the widespread effects of hearing loss on the brain. There's been more studies come out in the last 5 years, and we've got a couple more coming up soon we'll talk about, than ever before. Understanding what happens actually inside the brain is the most important thing, and we are just on the doorsteps of understanding. Now, let's do this. The talk is on hearing, listening, and cognition, so let's define that first. The link between hearing and cognition is addressing the difference between hearing with our ears and listening with our brains. I don't know why this slide came out small. My apologies. Now, hearing is nothing. It's just a sensory-based passive process. You hear when you're sleeping. Hearing occurs every moment of every day. Hearing is just a sense. Now, listening, that's an active process. It requires attending, paying attention. Listening is a skill, applying meaning to sound, establishing vocabulary, developing receptive and expressive language, internalizing concepts. Listening and hearing are quite different. And another small slide, my apologies. Now the ear's job is to deliver accurate, undistorted, natural, there's a big key word, not amplified, natural and complete sound to the brain. Now the brain's task is to compare and contrast the sounds from the left ear and the right ear with respect to loudness, timbre, timing, phase, processing, interpretation, applying meaning. Now cognition is our intellectual ability, such as thinking, reasoning, and remembering. Now, let's define two terms on cognition. There's two different levels of cognition difficulties. Now, they used to call it MCI, mild cognitive impairment. It's no longer called that. Mild cognitive impairment is now called mild neurocognitive disorder. Now, mild neurocognitive disorder is where you start to notice that you're just forgetting a lot of things that you should be remembering. Or a family member or a caregiver tells you you're forgetting a lot of things that you used to remember. That's a mild neurocognitive disorder. The second category used to be called dementia. It's not called dementia anymore. Now it's called major neurocognitive disorder. And that's kind of like the late stages of Alzheimer's or Lewy body, where you can't dress yourself, you can't feed yourself, you can't care for yourself. So there's two different levels of cognitive impairment. We're going to go back to a couple stats real quickly. Once again, how common is hearing loss? Third for people over age 50, behind arthritis and hypertension. It affects more than 30% of adults over age 50, and it roughly doubles for every decade after. Hearing loss is prevalent in almost 2/3 of people over age 70, and quite often it's untreated. Now, what is hearing loss? Hearing loss is defined as the pure tone average of 500 hertz, 1000 hertz, 2000 hertz, and 4000 hertz when it exceeds 25 dB, according to the World Health Organization. Now, one of the very earliest studies linking cognitive decline and hearing loss was first noted back by Dr. Christine Peters, and she is at the University of Nebraska, and it was in the Journal of American Geriatrics in 1988. That's 34 years ago. Now, two slides on Dr. Peters' study. First, her studies concluded that cognitive decline with people who have hearing loss was much greater than people without hearing loss. Additionally, this study noted that early diagnosis and management of hearing loss and dementia are extremely important in reducing and delaying cognitive decline. Now, in 2011, Dr. Laura Lemke, her study revealed that early diagnosis and treatment are the most important in identifying and reversing factors which may, if not recognized, may rapidly cascade. I cannot tell you how many times I've heard people say, I know I had a hearing loss over the last couple of years, but things have just gotten so much worse. It's logarithmic. Also, Dr. Leek put out the fact that early identification allows the patient and their loved ones to better prepare financially and emotionally for the future. Now, really the beginning, 2013, Johns Hopkins. Most of the best studies on cognitive decline have come from the the Center for Neuroscience at the University of Colorado, Dr. Sharma. We're going to talk about her. Amazing studies have come out from the University of Bordeaux in France. But some of the most important studies, and this landmark study back in 2013 come from Johns Hopkins, hearing loss and cognitive decline. It's a remarkable study. I've got 4 slides here, which are kind of a synopsis of this landmark 2013 study. First, Johns Hopkins study reveals that the risk of dementia becomes evident for hearing loss greater than 25 dB, and it increases with more severe loss. The risk of developing dementia doubles for Americans with a mild hearing loss. For people with a mild hearing loss, the risk of dementia doubles, and it triples for a moderate hearing loss. And for those with a severe hearing loss with untreated hearing, the risk is 5 times greater than normal hearing. Johns Hopkins research has found that what happens, once again, if you're not going to use it, you're going to lose it. Shrinkage of the brain tissue is fast-tracked with hearing loss, and it accelerates according to the degree of loss. Most of that shrinkage occurs in the speech processing parts of the brain. The longer you go not hearing clearly, the less success you're going to have once you decide to treat your hearing loss. And most of that loss of volume occurs right here in the temporal lobe and the auditory sections of the brain. Now, Dr. Sharma, one of the foremost neuroscientists on the planet at the University of Colorado Institute of Cognitive Science and Center for Neuroscience, found that brain changes, this is all about the brain, inside the brain, brain changes and cortical reorganization occur even with a mild hearing loss. What in the world is a cortical reorganization? Now, when the auditory cortex is not getting all the information, you have a 25 dB loss. What happens is the auditory cortex says, I need help. And it will send it out to the visual parts of the brain. It'll send it out to the somatosensory parts of the brain, which degrades the quality of the information. And this begins, the auditory cortex begins to send it out. Cortical reorganization begins with a mild sensory neural hearing loss. Here's another paper that came out from the Department of Medicine, the University of Pennsylvania. And it goes back to the fact that their studies have proven or shown that cognitive decline with untreated hearing loss begins at a mild hearing loss. The Journal of American Geriatrics in 2015 did a 25-year study, 25 years. They followed over 3,000 participants. And we can sum it up with 2 findings, which were in the conclusion. Number 1, accelerated cognitive decline is reported between normal hearing and untreated hearing loss. Number 2, there is no difference. There is no difference in decline. There's no difference in decline between normal hearing and those using hearing aids. We're going to talk about Dr. Deal at the very end of our talk. 2018, Dr. Deal put an article in the Journal of Gerontology, which basically says a 10 dB decrease in hearing thresholds may indicate up to a 14% increase in dementia. Here's my favorite study. It's not really a study. What it is, the British Society of Audiology put together a whole bunch of different researchers, University of Bordeaux, Johns Hopkins, all these great studies, and they're all in this one article. And you can get this article on the internet. British Society of Audiology put in this date right here, and it's just everything in one little place. It's a multiplicity of emerging reports and basically concludes, and the conclusion says hearing loss is associated with accelerated decline for individuals with dementia. Now, I think I've got 4 slides here just on that one multiplicity. So this is actually not from one group, it's from a bunch of different groups. Basically, that hearing loss and cognitive decline occur in parallel severity. Now, what that means is the more severe the cognitive decline, it's directly associated with the severity of hearing loss. Remember a moment ago when I was talking about how it has to go out to different sources to get help? Hearing loss increases the demand on cognitive resources. It needs help from visual, it needs help. And what happens is you have information degradation, it goes down. Even with the mildest untreated hearing loss, people struggle to hear speech in conversations, especially in noise. Now, when you take 2 different factors, cognitive decline and to put together with hearing loss, that outcome is worse than the additive sum of the 2 individual factors. And we talked about this a little while ago. People who have hearing loss have increased amounts of difficulty. And I think this is the last slide from that one, which is the risk of dementia associated with hearing loss appears to only increase at hearing thresholds of greater than 25 dB. Now, 25 dB is where you just start to have some difficulty understanding speech. 25 dB is pretty much what you get when you use the little earplugs. Once again, if you have normal hearing, walk in the shoes of somebody with a hearing loss. Put these in, wear them for a few hours, communicate, watch TV, have dinner around the table, and you'll get the idea of what a mild, I hate to use that word mild, because it's not mild, but a mild hearing loss will affect. I've got about 4 slides on tinnitus. And the only reason, and they come from different sources. Now, the only reason I put them on here is I've heard people ask, does tinnitus affect cognition? What is tinnitus? Tinnitus and tinnitus are both proper. You can say tinnitus, you can say tinnitus, they're both proper. Now, tinnitus is a perception of sound without acoustic stimulus. Now, when I have my device on, I don't hear my tinnitus. When I put it on, it masks out probably 80% of it. My tinnitus sounds like a high electrical wire, and it's always there. My poor wife, I have to have the fan on at night to mask out the tinnitus, which is primarily in my right ear. The journal, Clinical Experimental Otolaryngology, January 22nd, 1922, finds that tinnitus patients have more difficulty with attention span and memory. You remember the questionnaire I showed earlier, the tinnitus handicap inventory? The higher the score, the lower the Montreal connectivity assessment scores. The Journal of Audiology and Otology, January 2019, shows that tinnitus severity is strongly linked to the extent of cognitive impairment. The Journal of Neurophysiology shows that tinnitus patients show a significant deficit in learning word lists, learning rates, and recall. All right, here's my favorite part. How do we intervene? Make sure I got this lined up properly. All right. This study actually has been come out again this past year, 2022. Originally, it came out at the Alzheimer's Association International, and it comes from the Lancet Journal. The Lancet Journal is one of the most prestigious medical research journals out there. All the top and the new and most relevant research on the planet often goes to the Lancet Journal. It's an amazing journal. Read the bottom. 40% of all dementia cases can be delayed or prevented. 40%. That means that 60% is DNA. If you got it, you got it. DNA, 60%. But 40% can be delayed or prevented. Now there's actually a couple more. But primarily there's 9 different modifiable risk factors. That means if you modify it, you're going to make it significantly less. There's diabetes, there's social isolation, there's hearing loss, there's obesity, there's depression, all these different factors. These are the modifiable factors. Now, in the next couple of decades, we're going to have more than 580 million people worldwide with significant age-related hearing loss. Now, of the 9 of the modifiable risk, the number one modifiable risk for preventing, reducing dementia was treating one's hearing loss. Treating one's hearing loss is the number one modifiable risk that you can do in reducing cognitive decline. Hearing loss has a significant impact on both our cognitive, our emotional, our psychological status. The Lancet says that the earlier that people with hearing loss are identified and treated, the better the outcome. Early intervention physically is for everything. Progressive is not good. Early intervention is everything. Now, the opposite statistic was shown. The opposite statistic was shown for people who wore hearing aids. People who wore hearing aids did not have higher cognitive decline than people with normal hearing. The last sentence right here. In other words, adults with hearing loss using hearing aids had similar rates of decline as those without hearing impairment. All right, the next 4 slides are going to sound complex, but please just hang in there with me and we'll work through it. Frontiers of Neuroscience 2020, Dr. Glick and Dr. Sharma. Basically what their study shows, and to put it together, is after 6 months of wearing a hearing aid, the brain changes itself. It's called neuroplasticity. The auditory cortex is not getting the information, sends out help to other places. You get your hearing device, you wear a minimum of 6 hours a day, it comes back to the auditory cortex. Sometimes it comes back in a different form according to how severe the loss was when you first treated. And what their study did is they did scans of the brain before and after. Before the person got the hearing device, after the person got the hearing device. And you can see in their graphs what happens inside the brain 6 months before, when they first get the device, and then 6 months after. The most important thing they said was the fewer the brain changes due to cortical resource allocation sending out associated with better speech perception. When a person says, my wife's been on my back for a while to get a hearing device, I knew I could hang tough, the first thing we say is you didn't hang tough. You have destroy or distort something, the most critical intellectual sense that you have. The earlier that a person receives appropriate amplification is a big word. There's a lot of devices out there. They're not set properly, or they're just amplifiers. Anyway, the less the brain recruitment, thus the person gets more benefit. The changes in the brain occur even with a mild hearing loss. People who wear hearing aids have shown a reversal of cross-modal recruitment, and it's normally something that occurs over a 6-month period of time. Once again, neuroplasticity is when the brain is not getting help to the degree it needs it. It's not getting all the information. So we'll send it out to other parts of the brain. Successful amplification candidate will undergo further changes secondary to amplification. Here's one of the handouts from John Hopkins information that we send with the packet if you have any interest in receiving our packet of information. And after I send it out, I don't do any follow-up. If you want to contact us, great. If you don't, then we respect that. June 2022, the World Health Organization states that the future of hearing healthcare needs a more person-centered and individualized plan tailored to the unique needs and profiles of the individual to maximize the nerve inside the brain. There are great audiologists out there. There are great devices out there. There are ways that you can program a device beautifully for a person so they'll hear clearly for the next 5 years. How well do you want to hear for the next 5 years of your life? So it's important, according to the World Health Organization, to find somebody who knows what they're doing. Glick and Sharma again, Dr. Sharma, last month, September 22, that she did a whole new study, and it's really in-depth, amazing MRIs, that as hearing loss progresses, structural differences in the brain become more pronounced. Also, she says that treatment with properly fitted hearing devices provided in the early stages of hearing loss, once again, the greater the loss, the less success later, has the potential to restore more typical patterns and improve cognitive function in most domains. If you're a musician, check out this book, Dr. Krause's book. Dr. Krause is right up there at the top of all the neuroscientists in the world. She has a brand new book that just came out a couple months ago called Of Sound Mind. And it talks a lot about what happens in the brain. It talks about all the different centers, the inferior colliculus, the superior model, very complex. What happens in all these different centers as the sound goes up into the brain? It's a beautiful book. It's a remarkable book. Here's some great trivia. When they did the autopsy on Beethoven's brain, they found the fissures in his brain were twice as deep and the convulsions were twice as common. A person who's a professional musician, they can understand speech a lot more clearly than a person with normal hearing. It's a remarkable book. It's called On Sound Mind. Look up, also Dr. Krause has a website called Voltbots. Voltbots. Anyway, so many great articles on there. And she shows how when the sound has little to no meaning, the brain responds one way. But if somebody says, hey, David, look over here, there's something that represents a meaningful idea, the brain does a different thing. And basically what she shows through these MRIs and all these electrode tests is that there is a sound brain partnership. And let's kind of end it the way we started it. Socrates said the ear is the organ of education, and Glennie, about 3 or 4 months ago, in synopsis said that listening is the foundation for learning. Now, what do you do? The Welcome to Medicare Act, we're going to talk about that in a second. There's great questionnaires. Cleveland Clinic has a great questionnaire. You don't want to get a hearing test. Do a questionnaire. Cleveland Clinic has how well do you hear? Do that. Now, the Welcome to Medicare Act says that when you are accepted to Medicare, you should be having 7 different tests. Now, one of the 7 tests, weight, height, all this type of stuff, all is a hearing test. You want to get a baseline when your hearing is good. No audiologist likes it. When a person comes in our clinics with a 40 dB loss or a 30 dB loss for the first test, how quickly is that hearing loss coming down? What frequencies are coming down? We've lost so much critical information. If your hearing is good, get a test. Now, one thing the test might not show that was a whole section I had to leave out of here is called hidden hearing loss. If I was a young audiologist, I'd be spending all my time on this because there are 26.3 million people in America with hidden hearing loss. And that's where your auditory sensitivity is perfect. You can hear very soft sounds perfectly, but the synapse between the cochlea and the nerve, there's something that's not right there. It's called auditory neuropathy. It's called auditory processing disorders. There's all kinds of different areas of hidden hearing loss, but hidden hearing loss is a person who has normal auditory sensitivity, but they have difficulty understanding speech, especially in a crowd. Hidden hearing loss. We're not going to talk about emerging technology. I only want to say this about emerging technology. The last year, I think it was like $550 million in research and design by the different hearing device manufacturers. This year, it's probably going to be over $650 million. Once again, it's the baby boomers. Hearing devices are getting so much better, and hearing devices, good ones, are no longer set on the hearing loss. Good ones are set upon brain hearing. What happens in the brain? The most important thing here is at the top. Every article you read says the same thing. If you want to hear clearly for the next 5 years, if you want to hear clearly for the rest of your life, establish yourself with seeking the lifelong treatment of an audiologist. You have a problem with a hearing device, you've got an audiologist there. You want it cleaned, you can walk into an office. So seek, it's not a bottle of ketchup. Seek the lifelong assistance, treatment from an experienced, stable audiologist. Now, hearing aids aren't going to make you have perfect hearing, but they don't have superpowers, but they will make a huge difference in your life. Hearing aids should not make sounds louder. Let me tell you, a lot of the stuff out there right now is nothing but amplifiers. People don't need amplification. They need clarity, clarity, clarity. It'll take some time. People say, I don't want to hear my clothes. I don't want to hear this. I don't want to hear that. It takes the brain a little while to reacclimate, to teach itself what to pay attention to, time and patience. If a person doesn't have time and patience, then it's almost better not to work with that person. And look for an audiologist who does the gold standard. There's a cheap way to do it, and there's a proper way to do it. So just make a decision on how clearly you want to hear for the next 5 years. Find somebody who's stable, good in the community, stable practice, medical model, going to do the real ear measurements. The real ear measurements is where you put a probe mic down the ear canal, you run the sound through the hearing aid, down the ear canal. What's hitting the eardrum? How are you going to tell what a hearing aid's doing? How? Unless you measure it. You can't monitor it unless you measure it. Real ear measurements. Make sure your audiologist does that. Hearing aids have been shown to improve quality of life, self-confidence, etc., etc. Here's what we're waiting for, and I'm hoping I'm going to give this talk again sometime in spring, because one of the greatest and the biggest and the most anticipated articles will be coming out from Dr. Jennifer Deal at the Johns Hopkins. It's coming out sometime in early 2023, and it's called ACHIEVE. ACHIEVE stands for Aging and Cognitive Health Evaluation in Elders. Now, the ACHIEVE study, when it comes out, will be the world's first, it's over 900 people that have been studying, more than 900. It'll be the world's first randomized trial to determine efficacy of best practices in hearing intervention on reducing cognitive decline for adults with hearing loss. Now, let's just sum this up. Conclusion: hearing loss has been described as a marker for poor health. Hearing impairment is not good for the brain. Despite the high prevalence and the consequences for hearing loss is largely undiagnosed and untreated. Why is hearing loss so undiagnosed? Think about it. When you talk to your doctor, where is he or she? Right here in front of you. And what are you in? You're in a nice little quiet room. A doctor can't notice your hearing loss because it's like saying, you know what? I can see my hand perfectly. So hearing loss is kind of like being very nearsighted. So hearing loss, unfortunately, is significantly undiagnosed. Request a hearing test. Do a questionnaire. Doctors do not routinely check for this problem. So it may come up to you to request it. 2/3 of older adults with hearing impairment do not use hearing aids. According to the Lancet study, it's the #1 modifiable factor on reducing hearing loss. Hearing loss is a medical issue. Untreated hearing loss has a multitude of medical and social consequences. Hearing care is health care. Now, if you have a question and you want to email me, please do. If you want, our packet of information on cognitive decline and hearing loss, contact me. We will email it to you. We will snail mail it to you. So you can email me, you can call me, or if you go to our website, hearinginfo.net, hearinginfo.net, a lot of this information is already on there. All right, I think we're ready for questions and answers. And I'm not sure we have somebody at Palomar Health to kind of help us with that. It doesn't appear so. So anyway, I'm going to go ahead and end today's talk. Please email me. Please call me if you have any questions concerning this talk. Also, I'd like to know how I did. How can I improve it? I know it was a little bit bumpy. I'm not a professional speaker. We did have some trouble with our slides. So what can I do to make this talk better? What questions do you have? I hope you all have a beautiful day, and maybe you'll attend our spring talk once John Hopkins, Dr. Jennifer Deal's Achieve study comes out. Thank you so much for joining us.